Excellent. Thank you, JD. Can you guys hear me okay? Awesome. All right. So today I'll be presenting a study that was done by one of my residents. Her name is Jennifer Martinez. And this was a study that came out of kind of personal interest since we see a very large population of dogs that get envenomated by pit vipers in Florida. We have a really significant population of very venomous snakes in the North Florida area. And in past experiences, we found that a good population of those dogs that were envenomated by pit vipers had developed some degree of AKI. So my resident Jen Martinez, Dr. Michael Scher, and myself went ahead and did a retrospective study, and I wanted to present it just because I think it was a non-conventional nephrology study, something that might spike some interest in some of you. So basically, the objectives of the study from my resident was to describe what clinical pathological characteristics of dogs that develop AKI in dogs that had pit viper envenomation could cause any correlation with the degree, severity of AKI, and potentially their outcome as well. Also, we were interested in seeing if the degree of coagulation values or the amount of antivenom administration that these dogs received had any correlation with the progression of AKI and the clinical course of these patients. So, um, in this study, we included all client-owned dogs that were treated at the University of Florida with at least one vial of antivenom following pit viper envenomation. And the reason why we chose to do one vial of antivenom as the minimum requirement is because it was going to be a lot easier to search in our database by invoice, since some of these very mild envenomations do not get antivenom and unfortunately don't always get registered as an envenomation in the system. So that was our consideration for potential inclusion criteria. And then in order to assess the presence or not of AKI, we included dogs that had at least two plasma creatinine concentrations measured within 48 hours during the course of hospitalization. So, just to give you a little bit of background, as you all can see, this is Florida, and Gainesville is right in the north central part of Florida. And I tell you, we have, in average, probably between 200 to 300 cases a year of snake bite envenomation. And probably the ones that we commonly see getting this worst degree of envenomation, worst degree of coagulopathy are those going to be that are attacked by eastern diamondbacks, which I have a picture of. This picture was taken by a friend of mine near West Palm Beach area. So these bad boys do tend to roam around in the Florida area. We do have also a lot of lakes and a lot of rivers and some springs, and we do have some water moccasins as well. They're also called the cottonmouth. And we also have some timber rattlesnakes, even though those hang out more in the area of Georgia, and they cause some neurological effects as well. And then the pygmy rattlers, which are probably the least venomous of all these pit viper snakes in the area. They do, depending on the time of the year, depending on the meaning of the bite, and by that I mean these snakes can deliver or can regulate the amount of venom they deliver, depending if they feel threatening, they just want to scare their predators away, or if they're really going to kill these animals. So the amount of venom definitely can be controlled by these snakes, and obviously some species seem to have more venom than others. So this is what we play with usually during the summer months. This is where the snakes are more active. During the winter months, we don't really see any snake bite envenomations, but as it is Florida, sometimes we get days in the mid 70s, mid 80s Fahrenheit during December or January, and these snakes seem to wake up and go for a hunt. So we do get them sporadically during the winter months. So, what are the consequences of these venoms? Well, most of them have uh, significant cytotoxicity, meaning that they tend to damage most tissues that they get in contact with. They also cause profound endothelial damage, and that endothelial damage is reflected on the cardiovascular consequences that we see in these dogs. And I have a video of a dog here that got bit on one of the legs, and as you can see, he's profoundly tachycardic, collapse, tachypnic. These dogs presenting a very bad degree of shock. As you can see, there is a wound with hemorrhage there, and we're bolusing antivenom because when we notice that these dogs present in this degree of cardiovascular collapse, usually these dogs get 2 or 3 vials of antivenom bolus because otherwise we lose them very quickly. So the endothelial damage that is seen definitely affects heart rate, blood pressure, and all their cardiovascular parameters. And on top of that, what most people is familiar with in terms of pit viper envenomation is the coagulopathies. So these dogs may or may not have profound external bleeding. It's uncommon to see internal bleeding. Most of the time, the bleeding comes from the local area where the bite was identified, and a significant degree of myonecrosis, which, talking about kidneys and potential myoglobinuria, that can also affect the incidence of AKI. As I said before, we don't commonly see neuropathies. Most of the time, we're going to see the cardiovascular, the hemorrhagic effects of these venoms. With the Timbler rattlesnakes that are more common in southern Georgia or maybe more northwestern part of Florida, sometimes we do see some degree of neuropathy in those cases. And of course, if when untreated, these dogs can go into complete cardiovascular shock and death. So since we're talking about the cardiovascular effects of the venom, our suspicion is that most of these dogs had what we call a pre-renal AKI, or an insult that was initiated before the kidney. So where the perfusion or the renal perfusion was compromised, either due to decreased flow, and that can be caused by the endothelial damage. Or from volume depletion in some of these animals that bleed excessively, or a combination of. When you have that compromised oxygen delivery and cardiac output is compromised, then renal perfusion is compromised, and therefore the risk of AKI in these animals. So the hypothesis of this study, first of all, was to investigate whether or not dogs that develop AKI with pit viper envenomation, do they have a longer stay in hospital, as it was seen in some studies in human medicine? Uh, does the dose of antivenom correlate with the degree of AKI, and whether or not there was an increased mortality? So we suspected that all three of these parameters will apply, that dogs that develop AKI will spend more time in hospital, will have larger doses of antivenom, and will have an increased mortality. So we went ahead and did computerized medical record search. This was between the years of 2008 and 2017. And as I said before, our search criteria was based on invoices where dogs receive at least 1 vial of antivenom. And then for the AKI criteria, we used the IRIS AKI, and we looked at increases in creatinine by more than zero point 0.3 or evidence of azotemia at the first blood work performed. Um, and in order to exclude any other potential causes of azotemia in these cases or perpetrating causes of renal dysfunction, we went ahead and excluded any dogs that had a history or medical records consistent with chronic kidney disease. And also, since some of these dogs were referred to our hospital from primary veterinarians, we excluded dogs that received any potential nephrotoxic dogs, and most of them are going to be NSAID administration during their acute illness. So, statistics part, as part of the methods, all the data was reported as median, standard deviations, and then Spearman rank order correlation was used between pairs of continuous variables. Then Crusoe-Wallis was used for non-parametric tests for continuous and nominal variables. And then basically for all analysis, a p-value of less than 0.05 was considered significant. So in our data search, we found 297 records. And again, this excludes any dogs that did not receive antivenom, and that definitely is a potential bias of this study. But after all the exclusion criteria and making sure all the records were complete, we included 63 dogs. Out of these 63 dogs, one dog had previously diagnosed and confirmed CKD, and 6 dogs received NSAIDs at their primary veterinarian before presenting to our hospital. So a total of 56 cases were included in the study. And based on the IRIS AKI guidelines, we divided the patients in this study with, within the AKI group or non-AKI group. So we had a total of 40 with non-AKI and then 16 with AKI. And as you can see from their age, weight, sex, there was no major differences in the presentation of these dogs from the AKI compared to the non-AKI group. Their temperature was not clinically significant or, statistically significant either. What we did find between these two groups of envenomated dogs is that their heart rate was significantly higher in those dogs with AKI. Their shock index, which is the parameter that we use to more objectively identify shock by using heart rate divided by blood pressure. Their shock index was a lot higher in pets with AKI compared to non-AKI. And then when we look at the dose of antivenom received, we use either vials of antivenom versus vials per kilogram of antivenom. And this was to be a little bit more objective in terms of, based on the weight of the patient, how much antivenom did they receive. And in both evaluations, dogs with AKI received substantially more antivenom compared to dogs with no AKI. And finally, in this initial evaluation, there was no correlation between coagulopathy or the prolongation of ACTs compared to the non-AKI group, which was a little bit of a surprising finding, but no statistical significance there. And then finally, as expected, dogs in the AKI group were significantly more hypotensive, with 75% of the dogs in the AKI group having a hypotension versus only 19% of the non-AKI group having hypotension. And then in this study, there was a significant correlation, even though it was right at the edge of 0.05 of dogs receiving 56% of dogs receiving packed red blood cell transfusions in the AKI group compared to the non-AKI group, where they only 27% had packed red blood cell transfusions. So these were all the clinical pathological variables that were evaluated in terms of the incidence of AKI in this population, and all these results are reported as a mean and a standard deviation. When we looked at these dogs, we classified them based on their iris AKI grading scale, and then we identified 4 of these dogs were in the grade 1, 4 also were in grade 2. The majority of the AKI group fell into the grade 3. Interestingly enough, we didn't have a grade 4, and then only 1 in the grade 5 category. None of these dogs became oligoanuric, at least based on the medical record search, and none of these dogs require dialysis, obviously taking into account that some of those dogs were euthanized. So in a multivariate regression analysis, we tried to identify whether the severity of the AKI was correlated with any of those clinical pathological variables. And what we identify is that intact females had a higher chance of having worse degree of AKI. Even though this was almost at 0.05, really couldn't, based on these small numbers on each group, it's hard to say whether or not this is clinically significant. And then, interestingly enough, the severity of AKI was correlated with the receiving packed red blood cells. So transfusions seem to be correlated with the severity of AKI based on their iris grade scale. And in terms of outcome, as it was hypothesized, dogs in the non-AKI group had better survival, with 98% of them leaving the hospital. Only 2 of these dogs in the non-AKI group were died in hospital due to their envenomation. And in the AKI group, we had a lower survival. The dogs, only 31% of these dogs survived to discharge, and 44% of these dogs died in hospital due to the severity of the envenomation, and 33% had were euthanized in hospital. So, as you can see, the clinical outcome in the AKI group was a lot worse. Since we were interested in evaluating the degree of coagulation with outcome of these patients and the AKI severity, we went ahead and looked at the different time points in coagulation parameters, so baseline ACT, and compare that to length of hospitalization, total dose of antivenom, shock index, and iris grade. And we also did the same for final ACT and average ACT during hospitalization. And again, the correlations here were mostly weak. They were not very strong correlations. But as you can see, the dose of antivenom definitely correlated with the degree of coagulopathy at presentation, with higher total vials and vials per kilogram. Doses of antivenom correlated with baseline ACT or more prolonged coagulation times. In the final ACT, there was no correlation with days of hospitalization or dose of antivenom, more with shock index. And finally, the average ACT had a correlation with total vials of antivenom and shock index. So again, these correlations are very weak, and because of the low numbers, it's hard to say whether or not they will persist in a larger population study, but there were interesting findings to look at. So based on those studies, this is just another video of what these dogs present like. Most of the time, owners find the dogs find the dogs fighting with a snake, or they suspect a snake based on the fact the dog was outside. They heard the rattle, and they live in a swampy area. So these dogs present in a very severe state of shock and with significant coagulopathies. And talking about pre-renal AKI, something that we in the critical care world kind of are dealing with most of the time because of that decreased oxygen delivery in critical states. Most of the time we're looking at problems with preload, and again, that includes endothelial dysfunction when there is severe vasodilation and poor stroke volume. An increase in afterload is less likely in these cases. Just as most of them are hypotensive, there is no really evidence that there is an increased afterload in these cases. And then problems in contractility, and as some previous studies have shown in pit viper envenomation in dogs, especially with Middle Eastern pit viper, they can have significant cardiomyotoxicity, and they can have significant arrhythmias, which in this study we did not look into. So both of them, all of them can decrease the stroke volume, can decrease the cardiac output of these patients, and finally, as a consequence of that, have decreased renal perfusion. In some other, so as far as we know, none of the American pit vipers have a direct nephrotoxin in their venom. There are some pit vipers, especially in Asia, where the Russell pit viper does have nephrotoxin with patients that, with human patients that being envenomated, having AKI without significant evidence of cardiovascular collapse, and as well as in South America. In South America, we also see. I apologize for the noise. In South America, there is also um, pit viper that can cause significant AKI without cardiovascular compromise. So, as part of the discussion in this paper, as an interesting finding, we had the incidence of AKI being 29% in pit viper envenomation. Again, there is an intrinsic bias based on the fact that not all pit viper cases were included, only those that received antivenom. So we had the intrinsic bias in terms of selecting for a population that required antivenom administration. And the requirement of antivenom is clinician based, and I would probably say that most of our experience in pit viper envenomation tells us that patients presented with coagulopathy or cardiovascular compromise, so prolonged ACTs, hypotension, tachycardia, those are patients that will immediately get at least a vial of antivenom. The dose of antivenom, there is really no good way to dose antivenom. Most of the time it's subjective and based on clinical experience. I'll probably say we do have a snake bite severity score, and the use of that snake bite severity score is intermittent amongst clinicians, and unfortunately we could not address that in the statistical analysis of this study. So based on the fact that none of the American pit vipers have a reported nephrotoxin, and based on the correlations of AKI and degree of shock index, hypotension, and tachycardia, we assume that the main mechanism underlying AKI is hemodynamic compromise. There was a correlation between the dose of antivenom and AKI. And we believe that that's likely related to the degree of envenomation itself, because as I said, dogs that had worse clinical presentation in terms of their envenomation score or the subjective evaluation of the clinician were more likely to receive higher doses of antivenom at presentation. And then out of our hypotheses, the only one that we did not find was the fact that there was no association with the length of hospitalization and the development of AKI. And this is in contrary with what you find in human literature, based on the fact that some people may go on and require hemodialysis. We assume this is likely related to euthanasia, as these dogs, some of these dogs that had really bad AKI, and due to owner finances, these dogs may have been euthanized due to poor prognosis given by the clinician and financial aspects of it. So, in terms of the limitations of this study, I think that probably one of the biggest limitations with any retrospective study is those intrinsic biases in terms of case selection, missing some cases that can be very mild. One of the things that we emphasized on was the fact that there was no consistent evaluation of EKG. And again, there are some studies looking at troponin levels in pit viper envenomation in some other countries. And again, we did not evaluate EKG abnormalities or troponin levels in these cases. And probably a big limitation of this study is that very few patients were in the different grades of AKI according to IRIS, with no patients in the group in the grade 4 and only one patient in the grade 5. So that really limits the statistical significance of those multivariate analysis where the degree of AKI cannot be correlated to specific clinical pathological presentation findings. And probably, as with any AKI study, the limitations of creatinine as a marker of AKI put a big pressure on whether or not there are more patients with true AKI, but because they don't have decreased function or significantly decreased GFR, then we cannot recognize them because their AKI never goes up or their creatinine never goes up. So the lack of clinical biomarkers puts a limitation on the results of this study, and sets us up for future studies in terms of can we look at these cases at presentation with some clinical biomarkers, whether it's NGAL or Kim18 or other biomarkers that are out there. So with that, that's a quick and short presentation of this study we did at University of Florida. I really want to thank JD and the group for allowing me to present this. I think this will be very interesting, kind of different types of AKI that we see in the critical care world, and I'm happy to answer any questions.
Thanks, Leo. That was great. I'll start off with a question. Do you see that their tachycardia resolves once you restore their perfusion, or is there any thought that there could be myocardial toxicity associated with the toxin as well?
Yeah, that's a good question. And, most of the time we see after we give them antivenom, we see improvement in their perfusion parameters. So degree of heart rate or degree of tachycardia, blood pressure. So we see a significant improvement after these patients receive antivenom. The other point is with the myonecrosis, local pain. And, these dogs, as you see in this picture, get very swollen. They're very painful, especially when they're bit on the limbs. Those animals are very sensitive. We never treat these dogs with painkillers at the beginning due to the fact that a lot of the monitoring we do in these patients is based on how alert they become after antivenom, or if they decline, they sometimes become very dull. So, you can make an argument that pain may play an effect on that degree of tachycardia, but that's why we do the shock index to be a little bit more objective in terms of is that tachycardia related to shock itself or any other parameters. And to answer your last question, which was whether or not antivenom has any effect on or the venom has any effect on the heart. With the cardiomyotoxicity, we'll expect to see potentially more arrhythmias, and most of the time what we're seeing in these dogs is sinus tachycardias. We don't see as many ventricular arrhythmias. We did want to do a study, unfortunately it didn't get funded, in terms of looking at troponin levels. I guess you can make an argument there is a degree of ischemia to the heart as well. If there is ischemia to the kidneys, can safely assume that probably coronary perfusion is not as great either, and you may have some degree of cardiac ischemia. Again, the lack of VPCs does not always correlate with lack of myonecrosis to the heart, but my guess would be that probably is not as significant as the degree of shock.
Great, thanks. I was wondering about the fluid resuscitation that you perform on many of these patients, and Stephen had also asked if there might be any indication to use vasopressors maybe earlier in their resuscitation. But what's your typical strategy? Are these dogs getting typically crystalloid boluses? Are any of these dogs getting synthetic colloids, and might that play a role as well? Or are they on pressors? Could you maybe just elaborate on what many of these dogs might go through?
Usually not on pressors. We put them on CRIs of antivenom if they're persistently hypotensive. And in terms of fluid resuscitation, we do give some boluses of crystalloids, mostly balanced crystalloids. We don't use colloids in these patients, or basically in our ICU, we don't use colloids or synthetic colloids. Some patients where hemorrhage is significant and their envenomation is ongoing, we do give transfusions right away, especially if their crit and total solids drop significantly within the first 4 or 6 hours. But to answer your questions specifically, crystalloids are kind of conservative because most of the time we're able to stabilize these patients with boluses of antivenom and antivenom CRIs, and then no colloids and no vasopressors, and some transfusions in the very bad cases where they just continue to hemorrhage. But I would say those that continue to hemorrhage and we're not able to stabilize with antivenom, those are probably the ones that end up dying in the first few hours.
Thanks. Julia had
Hello.
asked if you had ever seen any possible cases that you thought there might be nephrotoxicity associated with the antivenom. Has that ever been something that you've been concerned of?
Yeah, and definitely we've seen some cases of antivenom immune-mediated reactions. I guess in these cases where they're so sick at presentation, it's hard to say whether they're having a reaction and they're becoming hypotensive from a reaction or from the envenomation itself. The degree of reactions that we see to antivenom is very low. In one study that Dr. Sher is doing, he's only found less than 6% of dogs having a reaction to antivenom. In terms of direct nephrotoxicity from the antivenom, we did use 3 types of antivenom. One is a whole IgG molecule, and the other ones are Fab2. You can make an argument that potentially more immune response can be developed to whole IgG antivenom, and unfortunately we couldn't really do any statistical analysis on that because of the low number of patients, and depending on the time what antivenom was available, that was administered, so it wasn't really objective evaluation of that.
Hello, I have a question. Hello,
Yeah.
am I audible?
Yeah. Hello.
So I'm from India, Kerala, and here generally we get viper envenomations during the rainy season, May, June, July, August. So when they come at 3 a.m. in the morning, the residents take over. Mostly they are surgeons. surgery students. So they have a habit of administering meloxicam.
Yeah.
So, and we've got bad, it worsens like within 6-7 hours, the dog is okay on presentation, and then the creatinine has just shot up. So, is Melonex responsible and other NSAIDs? And if it is, like, what are the safer painkillers which we give? I generally prefer tramadol. Can you give me your thoughts on it?
Yeah, so as a rule of thumb in our critical care unit, we don't give NSAIDs to patients that are either sick at presentation or may have a risk of AKI. So we tend to avoid NSAIDs unless the patient is stable, we know what's going on with the animal, and potentially the patient is already eating or has a feeding tube and a plan to go home. So um, in terms of my personal opinion, I think that these dogs that are at risk from cardiovascular collapse should not get any NSAIDs. Pain
They,
management, again,
yeah,
we
pain
can,
management.
yeah, in terms of pain management, I would say that opioids, we do use opioids, mostly methadone. We do IV doses of zero point 0.2 mg per kg of methadone every 4 to 6 hours. Most of the time, using methadone was once these patients are stable. Again, the anti-inflammatory properties of the antivenom do help regulate some of the pain. And we like to wait a few hours until we feel comfortable the patient is stable enough before hitting them with some opioids. And you can try to use some gabapentin as well. I think gabapentin is being used more and more as a pain modulator. The biggest question is how much effect is going to have on a dog that maybe have GI hypoperfusion where absorption of oral drugs is compromised, and um, you know and in acute pain is kind of difficult to assess gabapentin effects, and the sedation that may be secondary to the gabapentin may be not useful in terms of monitoring these cases. So most of the time we're recurring to methadone or some full opioids. I guess you can make an argument for using buprenorphine or butorphanol as well.
So tramadol is not suggested.
No, I mean, we moved away from using tramadol first, again, because it's an oral medication, and in these acute cases, maybe not the best to give oral medications. Back in the days, I used tramadol to send these patients home, and if I look at it retrospectively, it probably didn't make a huge difference. And nowadays, more and more, we're moving away from using tramadol. Is it gonna cause any issues? Probably not. May help modulate a little bit of the pain, but we don't commonly use it.
And generally, here there's a concept that AKI will get cured within a week or something. I mean, I had a Dachshund, a snake bite was on the face itself, on the right side jaw. So he did not need dialysis, but he was in proper AKI. Like his urine output has reduced, and the creat was day of presentation it was 1.2. Then it within 24 hours it became 1.5. So we had to explain the owner, and it took me at least 1.5 months to get the dog stable, normal. And then we had used hot water fomentation also to get the swelling down. So we had used such home remedies also. So now the dog is stable. We keep an eye on it. So these are the options which we do. Of course,
Oh
all
yeah,
cases don't need dialysis, but then other things were taken care of: phosphorus binders, the renal diet, and plus the owner education was also given. So
yeah,
that's important.
yeah. We didn't have a lot of follow up in most of these cases. And that probably puts a limitation on whether or not what kind of treatment long term with phosphorus binder and renal diets is necessary. I'd probably say, in my experience, based on the cases that I have follow up personally, and again, there is no data on this, so don't quote me on this, but most of the dogs I follow up with, these dogs do well and don't require long term management. So just like as you expect with the pre-renal AKIs that respond to fluids, and most of them do okay.
Thank you very much.
Yeah.
Hey, Leo, this is Calgill. I wanted to ask you, the animals, obviously this group that has the AKI, there's a much greater mortality than the other group, and it didn't seem to me that their iris grading scores were all that pronounced. So, what do you think is the fundamental cause of mortality in these animals? It's probably not uremia, and is the AKI just put them in, in a defined category, or could they be categorized otherwise based on just the severity of their disease?
Yeah, most of the time it's going to be the severity of their disease, mostly because they're not responding to antivenom administration. And, a big part of it is going to be, the discussion with the owners, because each pop of antivenom is about $400. And I tell you, I pushed up to 24 vials of antivenom in less than 6 hours in a dog. And once you start reaching, certain amounts of money, I think that the owners start, thinking euthanasia should be the route. So that's why we made an emphasis on the fact that a lot of these dogs were euthanized, probably because of financial factors and the fact that they were not responding to treatment as expected. And I'll probably say that, Michael Scher, who is big, long story, researcher in envenomation, he never really put AKI as a prognostic indicator in these cases. Sometimes we'll see mild azotemia, but we'll continue treating them. I think that this research, or this retrospective study, that showed that consideration of AKI could be included in terms of prognostication for these patients. So the development of mild azotemia probably did not affect the outcome of these patients in terms of euthanasia decision. And I'll probably say too that some of these animals that presented, we lost due to severity of envenomation, and I do wonder if we had continued treating them, or we would have seen more cases in the grades 4 and 5 AKI. So it's a difficult question to answer, especially because we only have 16 cases in the AKI group. I think that doing a prospective study may help solve some of those questions.
The other reason I wanted to bring that up is with an anecdotal experience of one patient that presented very much like your really severe ones to our clinic. The dog got 3 doses of antivenom, and to our eyes and to our criticalist eyes, looked like it was going to die within an hour or two. Had generalized ecchymoses and hemorrhage and swelling, and as a kind of at the request of the criticalist, we did a plasma exchange on that dog, and it turned the disease around almost immediately. And so in an environment like yours, where you're seeing so many of these, I wonder if maybe that would be something that you might consider. It was magical, I think, the response that the dog had, whatever the plasma exchange was doing.
Very interesting. Yeah, there was a small study that came out of Asia. I think it came out in JVEC last year, that they were suggesting plasma exchange and saw some positive response. I can forward that to you. But we have thought about it. We have considered it. I think that the concern we always have is this, placing a large catheter in these coagulopathic patients. And based on the fact that we do see significant response in a lot of them with aggressive antivenom therapies given, having a conversation about the risks of placing a large bore catheter on the jugular is always that we keep in mind. I don't know how coagulopathic is the dog you had, but in our cases we see external hemorrhage almost all the time with these very severe cases. So we always worry about putting a jugular catheter for plasma exchange in the acute phase. I think that maybe once they're more stable, potentially you can make an argument to do TPE to reduce the amount of antivenom they're gonna need during hospitalization. But it's a good thought. I don't know if we're ready to take that step, at least in the how severe they present to us.
Yeah, well, this dog wasn't stable. I mean, if you waited till it was stable, it would be stable at room temperature. But because it was progressing, I mean, the disease was progressing in minutes. We actually had no bleeding from the catheter site, and I think it's just like we see in patients with thrombocytopenia that we treat, or patients that have other bleeding disorders. We put this catheter in, and it's not usually the major problem, but the response was just extremely dramatic, and so it's something to consider. And I think given the cost of the antivenom, the cost of the plasma exchange might offset some of that cost as well.
Absolutely, absolutely. That makes a lot of sense.
Some of these sick patients could even benefit from like a cytokine filter or something like that to potentially help, which might be cheaper depending on the size of the dog, rather than paying for plasma and things like that. So interesting to other resources you might be able to pull for these patients that are sick.
Yeah.
So is 28, is that the highest number of vials you've administered to a patient?
Yeah. To my recollection, yes. 28 vials.
that seems insane.
Yeah, when I talk to people from Colorado or like North Carolina, where they mostly see the copperheads, they're like, we never give that much. I'm like, well, you don't have the kind of snakes that we have in Florida.
Right. My gosh, that's crazy. And you said that the dosing is really not well standardized. So are you basically just looking at the clinical status of the patient? They're still tachycardic, they're still hypotensive. You're going to push more. Is that what leads you
Yeah,
to
so
for the next vial?
so nowadays we do more the standard snake bite envenomation score, where it looks at 6 parameters: cardiovascular, respiratory, coagulation, neurological, GI, and local tissue, meaning degree of swelling and things like that. So most of the time we're reassessing 2 hours after presentation, 6 hours, and so on. Sometimes in these very severe cases, we're reassessing every 2 hours with ACTs and heart rate, blood pressure. So we're constantly reevaluating these cases, and some of them, you bolus antivenom and they just keep bleeding and they keep being tachycardic and losing blood. And I probably pushed as much as 4 vials within 1 hour, and see clinical response in some of them. So yeah, you're right. It's basically we're on top of these patients because we know if we don't stay on top of them, they're gonna die very soon.
Leo, I also forgot to mention that it's been reported on our renal replacement round. Some of our colleagues in Europe, particularly Italy, have used plasma exchange for viper venom and venomations there with more experience than what we've had in San Diego. And they also report that the plasma exchange seems to be kind of a turn the corner therapy for whatever
Yeah,
virus they see.
yeah, and in this report from Asia too, they did seem to have a very good outcome as well. So it's definitely something to consider. I'll probably have a difficult time, getting the rest of the team on board, but it's definitely something we can look into for sure.
Are you aware of any risks with a dog that, let's say they survive and then they get bit again, 6 months later? Is there a risk of second exposure to the antivenom, depending on the type of product it is, for them to have become sensitized to it? If it's the
Yeah,
whole, you said one version's an IgG based, is that right?
correct. The The one that we get from the United States from Beringer is a whole IgG. The ones that we get from Argentina and Costa Rica are Fab2. And Michael Scher has written a few case reports where they do have persistent reactions after multiple vials. I don't think that we've seen it as a second doses of antivenom, several weeks or months later. So I guess it potentially can happen. How we documented it, no, but definitely with whole IgG molecules, we've seen more reactions than with the Fab2.
It's interesting. And I'm guessing you guys aren't doing any pre-medication like some people might do for a transfusion. These patients aren't getting steroids, they're not getting diphenhydramine
No,
or anything like that.
no, we don't really pre-treat them. We just basically hang a dose of epinephrine ready on their cage, and we monitor them very closely for development of hives, vomiting, or anything that is outside of the cardiovascular parameters that we frequently monitor. But again, we see less than 6% reactions in most of these cases, and most of the reactions are very mild, so not very common.
Do you think if you were to look at like SOFA scores or illness severity scores, do you think those patients who had AKI were just sicker patients, kind of following up on Larry's comment that the uremia wasn't terrible? Do you think they were just overall sicker?
Absolutely, no doubt. And again, we do believe that the mortality is more associated with the degree of envenomation rather with the AKI itself. I think that AKI here in this situation is mostly secondary, and with multi-organ failure along in those lines, to the degree of envenomation rather than the uremia causing the mortality in these patients.
Terrific. All right. Are there any other questions? I feel like I've been partially hogging things as normal. So, any other questions from anyone in the audience, either through the chat or feel free to turn on your microphone? I can't say that we deal with any. Well, while you could say there are plenty of snakes here in Washington D.C., they're not the ones. They're not the ones that are biting dogs routinely. So we're not seeing any snake bites here.
But a lot of snakes.
More than anywhere else in the world, actually.
Well, thank you for the opportunity. I hope you guys enjoyed the presentation, and I appreciate all the comments, and we'll definitely look into the TPE for these dogs in the future.
Yeah,
Thanks, Leo. It was a great presentation.
Thank you.
Thanks so much for that, and thanks everyone for attending. I do not believe we have someone scheduled to present in 2 weeks' time, so I think our next presentation is actually in 4 weeks. Dr. Hattie Syme will be presenting, and stay tuned. I will post the recording on the website, and I will send an email out when I have. And as always, please feel free to sign up to present throughout the year. There's still plenty of open spaces, so we'd love to have you participate. And again, thanks so much, Leo. Really appreciate it. Hope everyone has a wonderful weekend.
You too. Thank you.
Take care, everybody.